Xenostomy, sir, 3 feet from DJ. Patient is currently vitally stable, sir, only accepting stoma output of around 1.8 liters. Her input output charting we have done, sir, it's within normal limits. Otherwise, her systemic examination reveals mild bilateral crepitation, sir, which has improved over the past 3-4 days. We are going on with active chest physiotherapy and dressing her. She has a burst abdomen for which we are doing twice daily dressing with paraffin and Robos. She has a purulent collection as well. In the processor, we are doing thorough saline wash.
Zahid, what is the burst abdomen and what is wound digestion? Come in. Come closer. Don't stay far. What is the difference between the two?
When the bowel is exposed, sir, it would be considered as a burst abdomen, sir.
The burst abdomen is a type of wound dehiscence, sir, where all the layers of the abdomen is open, including the rectus sheath. Wound dehiscence, the skin, the subcutaneous tissue is open, or with or without the
So, wound dehiscence is basically a term means dehiscence of a wound. It is not abdomen all the time. Any wound that dehisces is wound dehiscence. It could be one layer, it could be 2 layers, it could be 3 layers. When all the layers are open and you can see the viscera, that is burst abdomen. And burst abdomen is also a type of wound dehiscence, as you was rightly said. Why do you think Ayush, she developed wound dehiscence? And now I look at the brighter spots only.
The patient, intraoperatively, the patient had almost 1 liter of...
Is it all intraoperative problem? Because of?
So it could be due to the surgical site infection.
Okay, can you add to that?
So,
One? No? Okay.
So there's patient factors and there's disease as per se. Patient factors are pure poor nutrition, the disease in itself, and these two would have contributed. And other factors would have been the surgical site infection and non-sterility during the operating procedures.
Yes, Terry?
Sir, and poor immune status of the patient due to immunocompromised status. So, and like if thorough wash might not have been given
That
intraoperatively.
is technical. So,
Technical.
factors could be related to the patient, to the surgeon, to the operation theatre, to the disease, and so many factors. Patient-related factors would be nutrition. One, naturally, the kind of disease that the patient had. The patient is immunosuppressed due to malignancy, on chemotherapy, radiation, hyperproteinemia. All this is patient factors, no? And then, what was her illness? What was she here for?
So she presented to us with perforation peritonitis.
No, that's okay.
Her
Perforation peritonitis is a disease of fit people or unfit people?
unfit people.
Now, what do you think was the etiology of this perforation?
Given the demographic of our country, tuberculosis is one of the first differentials.
In this case, that's what you thought?
Yes, sir.
Is
Because
there
she
a
had
common site for tubercular ulcers? What is the most common site, Ayush?
ileocecal
A terminal ileum. So where was this perforation?
Sir, this was at because there was dense adhesion, sir, present between ball and the parietes. Initially, we couldn't assess the length of it. When we tried sharp dissection, adhesiolisis was done. We found a perforation at 5 feet from the DJ, sir. ICJ was, we could not appreciate ICJ well because
Okay,
it was
so it
dense.
wasn't in the proximal bowel anyway. That's what you're saying?
Yes.
Although you couldn't make out. That's the money.
You had multiple tubercles,
So that's one possibility, correct, good. What else?
mesenteric lymph node.
No, that's tuberculosis.
Yes,
So
sir.
that's okay. So etiology was tuberculosis, according to you. Any other possibility?
So typhoid.
So typhoid perforation is also a possibility. Both happen in the terminal ileum.
Yes.
Do you know why is it common in the terminal ileum, Ayush?
So blood supply of the...
One is poor blood supply, two, more stasis, increased pressure, and
Pierce.
pierced patches of the lymphatic glands. All these contribute.
Sir, for the perforation segment,
We
it was,
prepared a stoma.
yes, sir.
Why did we make a stoma? Why didn't we anastomose?
Sir, the pre-op, we calculated the pre-op Apache's 2 scoring, sir. In that, the Apache's 2 scoring of this patient was 17, sir.
Okay.
So we went ahead with stoma form rather than
That's
resection.
nice. That's one objective way to do it. Suppose it was 21.
Sir,
Suppose it was 21. What difference?
we need to reset the patient and bring the score down to 11 to 20 and then take up the patient for surgery, sir.
Before that, what do you do? What do you mean by resuscitation?
So we need to manage with the fluids, sir, antibiotics, and make sure the patient other systems like respiratory, taking of respiratory, cardiac, or even the
More?
AKI.
Brain. Sorry.
So preoperative fluid management, sir. And sir,
Pain.
patient pain should be managed along with sir appropriate antibiotic.
That he has said already.
Abdominal drain be placed.
Could have put a drain to the top. You can then do a lavage using saline. I think you Terry come in front because they won't answer anyway. Either Ajay. So you take care of the patient, then of the disease locally, and we use Apache 2 scoring in taking that decision so that you have a resident-proof approach, surgeon-proof. So one surgeon doesn't do anything differently. You were starting to say there was 1 liter of pus or whatever. That answer doesn't fit in because you may have a young patient who has 1 liter of pus in the abdomen, and you can have an old patient with only 20 ml of pus in the abdomen. The two may behave differently. Therefore, the score is a better way to assess it. Okay?
Yes.
So we know the factors here. So which factor do you think has played a significant role?
Patient factors have played a significant role here.
Very good. So what patient factor is correctable at this stage?
So at this stage, the immunocompromised status because of the tuberculosis can be corrected because we have started her on ATT. Then the nutrition factor, because she was preoperatively, nutritionally she was malnourished, we have started her on albumin and other nutritional sources. And we have already also managed her oral intake. We are charting her input and output, so we can, according to that, we can increase her input to match her outputs.
And of course the sepsis is not
And yes,
gone,
it's a
no?
sepsis.
Sepsis itself is a catabolic state. So what is a catabolic state, Vikhot sir?
Breakdown of all the protein, carbohydrates, and
So it's like breaking down of proteins maybe. And what are proteins? They are enzymes. And they are required for everything that happens in the body. So it's the overall management of the patient rather than one problem that you are talking about. So be careful about and be clear on that it's a complete management, not just bowel perforation is a problem. You had a young patient or a patient with a predisposing or pre-existing condition versus say which one will have a better prognosis, traumatic perforation or a typhoid perforation?
So traumatic perforation will have a better outcome because the bowel in which it has happened is not pathological, sir. So non-pathological bowel.
So theoretically you're right, but I would have appreciated if you had answered that again, sir, it depends on the score.
Yes.
I give you a story. Traumatic perforation, 55 days old. So it is such a random thing. Therefore, when people talk loosely, traumatic is better, typhoid is worse. You are not right. So therefore, have a score. If it is a traumatic perforation which is 15 days old, the score would drop. And if it is a typhoid perforation only 1 day old, the score would be better. So therefore, isn't it better to have score as a predictor of outcome rather than the etiology? So that is what the whole idea is. Because automatic the score includes how many components are there in Apache?
So 13 components, sir, starting with age, sir, electrolyte level, sodium and potassium, sir, and sir, along with that, blood urea of the patient, creatinine of the patient, and sir, temperature, pulse rate, sir, and sir, mean arterial pressure is included, and sir,
And the GCS also comes in.
GCS
So you have everything incorporated. So that makes it a very compact score, very useful. There are other sepsis scores also which you should read about. But this is the one we use in our unit and it's reproducible, doable, and you can use it for therapeutic purposes also. Is that clear?
Yes.
Yes, sir.
Score of modified Jams part prepared for pre-pyloric perforation, sir. Patient is intubated, sir, but her GCS has improved. She's E4, VT, M6, sir. We are planning for, otherwise vitally she's stable, sir. She's off Nordic support now. Her abdomen, there's no signs of ascites, it's soft, sir. Bilateral drain has been placed, the right drain 60 ml of right subhepatic drain 60 ml for 24 hours, and the left pelvic drain is minimal, sir. Our NG output has been 200 ml bilious. Her bilateral, on systemic examination, she has bilateral crepitation, sir. Her abdomen is soft. Otherwise, CNS, she has E4, VT, M6, sir. He's currently planned for extubation, sir. We've worked the anesthetist in loop and trying to give an extubation trial as for today.
Anything more you would like to say in addition to what Surya said just now? It's almost completely described, but anything more?
Metallurgical investigations reveal, sir, blood counts are normal, sir. HB is more than 10, sir. And, sir, electrolyte panel is normal, sir, for the patient, sir.
Which electrolyte is important record, so at this point?
So at this point, sodium, potassium, as well as other investigations like albumin and creatinine as well.
Which more electrolyte?
So, potassium is more important here because hypokalemia might be the most common cause of
Paralytic ileation available.
One is the paralytic ileus with potassium. And how the role of calcium here?
Sir,
Important, right?
yes, sir.
That also is. Is there any connection between the serum calcium and serum potassium?
Sir, so calcium is also absorbed in the distal portion of sir, along with the potassium gradient is important for the absorption of calcium in the
Yes, one and
Kidney also the Romke channels are activated because the Romke channels, magnesium and calcium go inside the kidney, sir.
so the third electrolyte is magnesium. So potassium, magnesium and calcium. And unless you know why, you would be doing what they do. It is like fixing up a puncture, putting up a tire and not knowing why you are using it. That doesn't make you a surgeon, that will make you a technician. And there are enough technicians in this country as it is all over the world. Be a surgeon, which means a scientist who knows what he is doing. Now, we did a modified Graham's patch. What is that?
Sir, in modified Graham's patch repair, sir, if we find a prepyloric perforation, we use a pedicle of momentum which is well vascularized, and then we suture it with the edges of the perforation, sir.
So, if it is in a patient who's got a score, you didn't mention score here, so would it matter?
sir. No. We don't know.
Sir, preoperative Apache scoring would matter, sir, because as the patient has not been extubated post-operatively, so sir, and patient was also on vasopressor support, so there are chances of bowel, there will be splanting vasoconstriction, so sir, healing will be impaired in the bowel and also in the mental region. Sir.
Impaired healing. So, what was there? What more you could have done?
So diversion, feeding.
Sir, in this patient we could have, first of all, we could have passed the right tube beyond the perforation, sir, and run a feeding jejunostomy so that the patient is not nil per oral for the extended period of time if not extubated.
I'm glad I remembered. This is what I said day for yesterday. So you should know what you're doing. And what are the, Junaid, what are the diverticalization procedures? And do you name the diverticalization procedures?
Sir, lateral duodenostomy we can do, and retrograde duodenostomy along with feeding duodenostomy, and we can pass the nasogastric tube beyond the site of perforation, so that we can decompress the duodenum.
What is triple tube?
Triple tube is nasogastric tube, retrograde duodenostomy, and feeding duodenostomy.
Some people do gastrostomy.
Yes,
The
sir.
classical triple tube is gastrostomy, feeding jejunostomy and retrograde duodenostomy. So there are three openings. Three. You understanding what I am saying? That is triple tube, classical. This is done for giant duodenal perforation. What is a giant duodenal perforation?
So greater than 2 centimeters in size.
Greater than 2 centimeters. Some people say greater than 1 centimeter. Not 3. 3 is not. 3 is huge. Gastrostomy, retrograde, and feeding. And putting a serosal patch. The same is covering this. So 1 tube, 2 tube, 3 tube. That was the concept of triple tube. The other option that Junaid was mentioning, which we do very frequently, putting in a Foley's to do a lateral duodenostomy, feeding J and retrograde. And nasogastric tube takes care of the stomach part. There are many options. Some people have also used a T-tube inside this, or they have done that CBD C-tube. So there are no bile reaches here. Feeding J, gastrostomy. So in any case, you need to, this is called diverticalization. It is done for large duodenal ulcer perforation, not small ones. Usually these are small, tiny perforations. But when it is more than 1.5 centimeter, it's large. And if you repair it, it will give way. Why would it give way? Because it is large in the first place, because patient has low healing power. Usually a sicker patient. Ram, is it the acute duodenal ulcers that perforate or the chronic ones?
It's acute duodenal ulcer perforate, sir.
Why acute?
Sir, chronic duodenal ulcer, it's healing by fibrosis.
So chronic will have more of fibrosis. So in which cases, I give you a hint. Nitish, in which cases the chronic can also perforate? In which patients?
Fibrosis is impaired.
So where is it impaired?
Healing is poor in that.
Who are these patients?
Nutritionally deficient patients.
Immunocompromised. Patients on steroid therapy, hypoproteinemic. So they won't be healing. That's where the same, it will behave like an acute ulcer. What is wrong in this endotracheal intubation? Please tell me all the. There are 5 problems with your intubation right now.
There should be, sir,
So bite
Noodles.
blocker should be there, sir.
There should be a bite blocker, otherwise the patient will be biting the tube. So there is a airway you can put it. Which you did not, you should put it. You would say the patient is edentalous, so can't bite, but it can compress, so the airway would suffer. If you don't have anything, you can put in a bandage roller. But keep it, so otherwise the patient is going to eat into or bite into the tube. How would you decide to extubate?
Sir, there are parameters we look into, sir. One is the pulmonary function of the patient. If the patient is able to breathe in spontaneously. How you assess this would be looking at the input volume inspirated and expired, as well as other parameters of ventilator would be looking at FiO2 less than 40%. If the PO2 by FiO2 ratio is more than 200, then we can give it a trial of extubation, sir, in that patient.
So always when you're answering, say that general findings, all the vitals
GCS.
and the patient's level of consciousness.
If GCS is fine, sir, and the efforts are fine, GCS is fine, patient is pulling the tube. It is itself an indication of extubation. If the ABG permits, we can extubate. Then we go to then ABG, then the ventilatory parameters. The patient is on spontaneous mode and maintaining, and the efforts are very fine, not using any accessory muscle, then it's an indication for extubation.
Right? And what is the step down? You extubate, then you forget it?
Sir, we step down to T-tube, first on spontaneous mode, then to T-tube. If the patient is maintaining saturation and everything is fine, then we extubate after the T-tube.
Is that clear?
Yes, sir.
So, patient also has a nasogastric tube which is, I think, sutured. Why is it sutured, Durya?
Sir, in case of pre-pylori perforation, we need to, because we need to keep decompression, 5 days we need.
So it's sutured to preventing the patient from pulling it out.
Okay.
So the tube has been passed beyond the perforation, the patient has altered
So
consciousness.
we don't want the position to change. That is the reason. What is wrong with this drip? If you don't know, it's alright. This is the best time to be in wet phase. Can you just lift up? Just lift up. What's wrong with this drip, sir?
So one is IV cannula should not be placed in the lower limb.
So why was it placed? One.
So we couldn't
What is the problem with the lower limb?
prevent, sir, one is predisposes to ambulation is impaired, and then it predisposes.
First is ambulation, and you're taking the farther you are from heart, longer it's going to take to reach there. Patient cannot walk, and then it can block very easily. So there's nothing good about doing it. But don't say it predisposes to DVT directly. Zahid, how will it predispose to DVT?
Sir,
Ram, don't waste my time. If you don't know, say you don't know.
sir, it can lead to immobilization, leading to.
So it can be by immobilization, but if there is thrombophlebitis, can that lead to superficial thrombophlebitis leads to deep vein thrombosis? How, Dr. Junaid?
Sir, actually the blood from the superficial system goes into the deep system, then it flows upwards. Sir. If the superficial system is already compromised, then the blood can thrombose in the superficial system. That will lead to impair function of the deep system also, sir.
So, I allowed him to go that distance because that's a wrong answer. Thrombophlebitis of the veins, superficial veins, does not lead to deep vein thrombosis. And I was asking why. I would have asked why it does not. So, don't try to go a long distance unnecessarily. You may get into trouble. Thrombophlebitis is inflammation followed by formation of a thrombus. So when it is a superficial thrombophlebitis, by virtue of the inflammation and fibrosis, the clot doesn't go anywhere, it remains stuck there. And it has nothing to do with the deep vein thrombosis. But here, due to lack of mobilization, it can happen. Thrombophlebitis is a superficial problem which can form a thrombus, tender cord-like structure, but it won't embolize. It is stuck. All inflammation leads to fibrosis, so it will be stuck. It won't be moving. Is that clear?
Yes, sir.
So there is a local problem related to that. How is the chest and why am I asking?
Sir, her chest she has bilateral crepitation present, but she's not in any fluid overload. We're maintaining input-output balance, so she probably has.
Why am I asking for chest, Ayush?
Sir, we have to plan to extubate the patient, sir. Patient must
Okay,
have.
Aman. A patient who had perforation peritonitis, duodenal ulcer perforation peritonitis, significance of respiration.
Basal atelectasis.
Basal atelectasis is what I am trying to look for. And don't hesitate in answering. In this unit, there is no difference between a first year PG and a third year SR. As long as they answer, don't ask. Clear? So, basal atelectasis should be anticipated, so we should start with chest physiotherapy early. And why is there basal atelectasis, Surya?
So one is in case of when the patient have pain, the moment of the breathing is hampered. Sir.
Actually, diaphragm is irritated. There is pain on breathing, so they don't ventilate as much. The lower parts of the lungs don't ventilate. There is atelectasis. What do you mean by atelectasis, Terry?
So atelectasis is when the alveoli are not able to open up, so alveoli because of the collapse of the alveoli, so atelectasis is.
What is basal pneumonitis? Is it the same thing? Yes, Ram.
It's a basal pneumonitis is inflammation of the alveoli of the
Due to stasis. If there is stasis, there is infection. And that leads to inflammation.
18-year-old post-op day 7, diversion jejunostomy, 2 feet from DJ sir for multiple pinpoint perforation was present 2 feet from DJ sir. Diversion jejunostomy has been done, sir. Currently, her vitals are stable, sir, and she is taking in oral intake is she is taking in orally, sir. Her output upon stoma is 1000 ml, sir. Input output has been charging on, and nutritionally we are monitoring, sir. Now her HB has come out to be 9.2, sir, which was initially 3.8. We are monitoring her blood parameters as well, sir. Currently, we are going out with chest physiotherapy, ambulation, and.
If I was to ask you one biochemical parameter to assess nutrition Sabyasachi, what would be that? Loudly? Some biochemical parameter to assess nutrition. What's so?
Iron.
Sir, the albumin levels we can
Okay, serum albumin.
serum albumin.
So what is the AG ratio like? What is the ratio? 6:1, 3:1, 1:1.
So 1:1.3.
Oh, I see. Come here.
Sir, her initially our AG ratio was
What is the normal AG ratio, Aman?
1:1.
Speak loudly.
1.7:1.
Yeah. See, you can crack MCQs, but the understanding is an issue. What did you say? 1:1, 1.7, or you said 1:3?
Say 1:1.3, sir.
Actually, albumin is more, sir. So it's 1.7:1. And what do you mean by reversal of AG ratio? I wanted to ask this basically, but I took a chance.
When the hypoproteinemia is the albumin level increase and albumin level.
What is the parameter or marker for acute nutritional loss? Acute, not chronic. इनसे क्या बोल?
Sir, free albumin.
Free albumin. Now you have heard it million times before, yaar. Not albumin. Why?
Albumin has short life, sir.
Short life.
Short.
Then why should you not use it? If albumin has short life,
Short half life.
if it had a short half life, it should be used for acute loss.
So the pro-albumin has shorter half-life, that's why we use it for
Pre-albumin.
pre-albumin.
What is the normal half life of albumin?
So it is 48 hours albumin.
48 hours. Albumin. I mean, इनके साथ ही रह तू. That will make you a wise man.
3 to 7 days.
3 to 4
7
weeks.
days.
Okay. That's why it will remain high. ये उल्टा बोल रहे हो. When you're looking at acute nutritional loss, you don't want something with a long half life. Otherwise, albumin will be normal for a longer time. You need pre-albumin or alpha transferrin in the LFT. Which is the Aman most sensitive LFT? ALT.
For nutritional status.
The ALT. I have changed the question. It's a broader question now, which actually depends entirely on the liver function. Not ALP. They have already said ALP. I said no. You are repeating the same.
Prothrombin time.
Prothrombin. Actually, PT. Prothrombin time is the most sensitive. There are others also, but this is a useful one. I remembered it when I mentioned alpha transfer.
Outside operated for gangrenous bowels post-op day 11 with resection of
Gangrenous
gangrenous
bowel due to what?
SMA thrombosis, sir. Due to SMA thrombosis.
The diagnosis is SMA thrombosis. Okay.
So post-op day 11, sir, she is with resection of gangrenous bowels, genostomy, sir. Currently, patient is conscious oriented. Her vitals are stable, sir. On examination, sir, she has bilateral. Her chest is closed, sir. She has bilateral crepitation. She is not maintaining saturation room air. Saturation is 92 at room air, sir, but maintaining with oxygen, sir, low flow oxygen. Per abdomen, sir, she has SSI at the midline, in midline, sir. But her stoma output is around 800 ml. Stoma is functional. She is taking in orally, sir. She is ambulating, and we are continuing with active chest physiotherapy, sir. Otherwise, other blood parameters, sir, she is anemic, sir. She has 7 HB of 7.3. Her counts are 13,000, sir. Other electrolyte, there's no electrolyte disturbance or any KFD derangement, sir.
She on some anti-platelets or anything else?
Sir, yes, sir. She's put on aspirin 75 mg OD, sir. Then silastazole and 100 mg BD, and then 100 mg BD, and then we have started on atorvastatin 40 mg HS, sir.
Why have we done that?
So she's a case of SMA thrombosis, so she's more prone to thrombotic.
Usually, what is the etiology for SMA thrombosis?
Sir, SMA thrombosis is secondary to a cardiac disease, mostly illness due to a cardiac disease, sir. Okay. So thrombosis.
So it can be patient may have prothrombotic factors. So patient may have a history of heart disease, so that embolus might have caused SMA thrombosis, sir.
Okay.
And, sir,
Any add? Want to add something? Sir, addega.
Sir,
The hypertension, which is the main
Hypertension leading to atherosclerosis.
So factors like atherosclerosis related with hypertension, also premature atherosclerosis, which is like Monkeybuck sclerosis. Monkeybuck is capital M, right? Monkeybuck M. Which in males,
Middle-aged.
middle-aged again male, M,
Medium-sized
then
vessels.
medium-sized vessels, and media is affected. So all 4 M's.
Patient also has a history of dyspnea or aggression grade 3, sir, and it's a 2D echo suggestive of left ventricular ejection fraction 25 to 30% with severe systolic and dysfunction with mild MR and TR, which is leading to hyperdynamic circulation, which can cause to embolic phenomena, which can lead to SMS thrombosis.
These, it can be either due to thrombosis happening there only locally, or it could be embolic. Superior mesenteric artery is a branch of which vessel?
Sir, aorta, sir, abdominal aorta, key branch of.
Is it the first branch of abdominal
No, sir,
aorta?
the second branch of her.
From where to where it supplies?
Sir, it starts from foregut, sir. Basically, sorry, it supplies the midgut, sir. I'm sorry. From the DJ junction to the proximal one side of transverse colon, sir.
Roughly there, yes.
From the ligament of Treats to the proximal one side of transverse.
So from the ligament of Treats to about the lateral 1/3 of the transverse colon, but that can't be measured. Where the final, what is the last branch of middle colon? And what is the artery of the foregut? UGs? Celiac axis. What are the branches of celiac axis?
So left gastric, sir, common hepatic and splenic artery.
What are the branches of common hepatic?
Sir, gastroduodenal artery, sir. Then
Main, hepatic main.
hepatic.
Main hepatic artery. Main, not right. That divides into right. And gastroduodenal artery is a straight artery which goes under the pancreas. You see that during Whipple's. What are its branches?
Sir,
Superior, inferior, pancreaticoduodenal? Maybe inferior is from somewhere else.
inferior is from the
Epiploic. Epiploic. Now what do we do with this patient? What all you would like to add?
Sir, currently, sir, we need to provide with active chest physiotherapy, sir. Her chest is poor.
She's
Otherwise,
got a short gut syndrome. No. Yes?
yes, sir.
She's recovered otherwise. And what did the CT angio show finally? Where is the block now?
Sir, it's in the SMA, this distal SMA, sir, where it has involved the whole of middle colon. From the point from the distant ileum, the jejunum, distal jejunum, ileum, ascending colon, and part of transverse colon has been involved. So distal SMA.
So now what do we do for the short gut syndrome? What is the short gut?
So when the length of the healthy bowel is, sir, less than 1 centimeter per kilogram body weight of the patient, sir.
Partly correct, so it can be anatomical or physiological. Anatomical is lengthwise, physiological if it is not absorbing, doesn't matter what is the length. Huh? That would be functional. So both are important for us. No? This patient is likely to have anatomical one. In fact, both. So what do we do?
So in case of short gut syndrome, we have to important will be the input-output charting, sir. The fluid status of the, because patient has a high tendency to get into IKI, sir. And we need to avoid hypotonic fluids mostly, sir, because patient will get dyselectrometers are very common. And nutrition we need to take care of, so these, and avoid sepsis.
So anything to add there? What nutrition you would prefer?
So simple nutrition simple carbohydrates should be given. So body has lost the ability to break down and absorb complex carbohydrates, complex proteins. So the simplest forms of the protein, carbohydrates, and fat should be given in the diet, sir.
And also we need to take care
Very
of
good. What else?
vitamin B12. There might be deficiency of vitamin B12 because terminal ileum.
So you'll take care of the macro and micro nutrients. Put it down properly. And enteral nutrition is superior to parenteral nutrition, but here you may have to supplement. The advantages of enteral nutrition are that there is no villus atrophy, it's a more physiological nutritional system. The transgut migration of bacteria does not happen and the cholestasis does not. Because the bile duct stops moving when the duct is not, bowel is not used. So, if you have guts, use them or lose them. So use them or lose them. If you don't use the guts, they will be lost. The patient would have transgut migration, septicemia, gram-negative septicemia, cholestasis, which will lead to jaundice, and then you can't even give parenteral nutrition, right?
Yes.
And then total parenteral nutrition is given through a central line. What kind of a line has been used, Ayush? here?
Sir, right side internal jugular vein catheter has been placed in the patient.
What are the other alternatives?
Sir, other alternatives include, sir, and central
Subclavian,
venous
yes,
catheter.
from this time. So, what are the problems that you can have with this catheter?
Catheter is associated sepsis.
Catheter related sepsis, CRS, or catheter induced sepsis. And how are they different, Vekotso?
Sir, for catheter-induced sepsis, if there is at the time of insertion, if there is no sterility maintained, it can cause.
Okay. How do you differentiate the two now that it has happened?
So you can take blood cultures and take a tip culture of the catheter and see if the same organism has grown, then it is because of that.
If the two have the same bacteria from the tip and from the blood, then it is catheter induced sepsis. If they're different, it is catheter related sepsis. Okay, that is your MCQ kind of stuff. CIS versus CRS. So CRS is when they are different. CIS is when they are same.